Welcome. Today we're diving into one of the most critical procedures you'll need to know, the arterial blood gas collection, or ABG. This is all about getting you ready for that NHA certification exam, so we're going to focus on the absolute must-knows, the key steps, the safety rules, and the stuff you've got to master.
All right, so let's jump right in. The very first thing you need to grasp is that an arterial puncture is a whole different ballgame from your standard venipuncture. Why? Because you're working with an artery. And that means you're dealing with a high-pressure system. This changes everything. Your technique has to be completely anaerobic. That means zero air can get into that sample. And when you're done, getting the bleeding to stop, or hemostasis, is going to take way more time and pressure.
So here's how we're going to break it all down. We'll start with why we even do this test. Then we'll cover all the prep work, how to pick the safest spot, and of course the step-by-step on the puncture itself. And we'll wrap up with aftercare and those critical errors you really need to watch out for.
All right, Section 1. Why arterial blood? So let's really get into why this procedure is so important for patient care, and why a regular old venous sample just isn't going to cut it for this test.
You know, you can think of an ABG as a direct snapshot, like a high-definition photo, of a patient's respiratory and metabolic health at that exact moment. It tells us exactly what's going on with gas exchange, that's the oxygen and carbon dioxide levels, and it also measures the blood's pH, so it gives us an incredibly clear picture of how well the lungs are doing their job and how the body is managing its internal chemistry.
And these results are a really big deal because they guide massive treatment decisions, especially for patients who are critically ill. We're talking about things like, how much oxygen does this person need? Do they need to go on a ventilator? Is a certain medication working? These ABG numbers are what doctors use to answer those questions. It's a high-stakes test that has an immediate, real-world impact. Now, because this is such a high-stakes procedure, you've got to remember this is an advanced skill. This isn't something just any phlebotomist can do. You absolutely must have advanced training, you need to be officially authorized to do it, and you need to keep your skills sharp. Always, always work within your authorized scope of practice. No exceptions.
Okay, let's move on to the prep work, and I'm telling you, this part is completely non-negotiable. Proper preparation is everything. It's what keeps your patient safe and ensures the sample you get is actually accurate. You cannot rush this.
So before you even touch a needle, this checklist has to be completed, every single time. You're verifying the patient with 2 identifiers, of course, then you confirm they've been in a steady state for about 20 to 30 minutes. That just means no recent changes to their oxygen support, so you get a true reading. You'll also need to check their history. Are they on any blood thinners? And you've got to inspect the limb itself. Are there any red flags, like a fistula, swelling, or signs of infection? And finally, you explain what you're about to do and really emphasize that they need to stay as still as possible. All right, Section 3. Now we're talking about choosing your site. And honestly, this might be the single most critical decision you make during the entire procedure. Patient safety really hinges on you getting this part right.
This right here is the golden rule, especially when you're aiming for the radial artery, which is the most common site. You must assess for collateral perfusion. What does that mean? It means you have to make sure there's a backup blood supply to the hand from the other artery, the ulnar artery. That way, if something were to happen to the radial artery, the hand won't be in danger. This is a massive safety check and a huge point on your exam.
And here's how you do that check. It's called the modified Allen test, and you need to know this like the back of your hand for the exam. You have the patient make a fist, you press down firmly on both arteries in their wrist, the radial and the ulnar. Then they open their hand, and it should look pale or blanched. Now here's the key part. You let go of the ulnar artery only. You're looking for that color, that pinkness, to rush back into their palm in about 5 to 15 seconds. If it does, you're good to go. If not, the test has failed and you cannot use that radial artery.
So you definitely need to know the hierarchy of sites for your exam. Think of it like a priority list. First choice, your go-to, is the radial artery. Why? It's got that great collateral circulation we just talked about, and it's superficial, so it's easier to apply pressure afterward. If that's not an option, your second choice is the brachial artery. And way down the list, usually only for emergencies, is the femoral artery. And just remember, as you go down that list from radial to femoral, the risks get a lot higher.
Now, these are your absolute hard stop contraindications. If you see any of these things at the site you're considering, you just don't go there, period. We're talking about skin infections, an AV fistula like a dialysis patient might have, a failed Allen test, or a lot of swelling. If you see this, you have to find a different site or you stop and notify the nurse or doctor. This is a non-negotiable safety rule.
Okay, Section 4.
we've done our prep, we've confirmed our patient is ready, and we've picked a safe site. Now it's time to actually walk through the puncture itself. All right, let's go through the steps. First, you get the wrist into the right position, extended about 30 degrees. You clean the site and, super important, let it air dry completely. Then you enter the artery with the bevel up at a 30 to 45 degree angle. Now here's a huge difference from venipuncture. You do not pull back on the plunger. The artery's own pressure will do the work and fill the syringe. Once it's full, you withdraw the needle and immediately get firm, direct pressure on that site. Then it's safety device, get any air bubbles out, cap it, and mix it by rolling it gently.
Let's just focus on that angle for a second, because it's so important. 30 to 45 degrees. That's much more shallow than what you might be used to with venipuncture, and there's a good reason for it. This angle gives you the best chance of entering the artery cleanly without accidentally poking through the other side.
3 to 5 minutes. That's the minimum amount of time you need to hold firm, direct pressure after the needle comes out. And I mean firm pressure. This is absolutely essential to prevent a nasty hematoma from forming. But that's just the standard time. What if your patient is on blood thinners?
And this is where that pre-procedure checklist you did really comes into play. If your patient is on any kind of anticoagulant or has a known bleeding disorder, that 3 to 5 minutes is not enough. You need to hold pressure for 10 minutes, maybe even longer. And then you very carefully reassess to make sure the bleeding has completely stopped before you even think about applying a pressure dressing.
Okay, last section, and this is a big one. The procedure is not over just because the needle is out and the sample is collected. Your job when it comes to aftercare and being able to spot critical errors is just as important as the puncture itself.
Okay, listen up, because this is your big NHA exam alert. I want you to pay very close attention here. These are the critical errors, the things that are always the wrong answer on your test. Pulling back on the plunger to aspirate the syringe? Wrong. Leaving air bubbles in the sample? Definitely wrong. Forgetting to document the patient's oxygen setting, not holding pressure long enough, or doing the procedure without being authorized, all of these are major, critical mistakes. Know them.
Just as important as knowing how to do the procedure is knowing when to stop. These are your stop rules. If any of these things happen, you abort the mission immediately. If the patient says they feel a sharp, shooting pain, that could be a nerve. If the blood you see is dark and not pulsing, guess what? You're in a vein. If the patient can't cooperate anymore, or if you see a hematoma starting to form under the skin, you stop. You pull out, apply pressure, and you're done. Pushing through is just too dangerous. So, you've held pressure, the bleeding has stopped, and you've applied a dressing. Your last safety check is to make sure you didn't compromise blood flow to the hand. So you're going to reassess that distal perfusion. That means checking things like capillary refill on their fingernails, looking at the color and temperature of the hand, and asking about any numbness or tingling. You need to be sure everything is still getting good circulation.
And that brings us to the final thought I want to leave you with. The procedure is done. You've cleaned up. But what are you watching for over the next 30 minutes? You always have to be thinking ahead. You're looking for any sign of a complication, renewed bleeding, any new swelling, the patient complaining of numbness, or if the hand feels cool to the touch. That constant vigilance, that's what separates a good phlebotomist from a great one. That's what ensures your patient stays safe.